Assalamu alaikum and good morning, everybody. First of all, I'd like to thank all the audience for joining us. And it's a pleasure for the Otolaryngology Department in Prince Sultan Military Medical City to share and direct the scope toward one of our challenging cases, which were encountered in our daily practice to discuss the diagnostic tool and options of management. Today, we will have a short case presentation by our consultant, Dr. Ahmed Tkhayil. Dr. Ahmed is a consultant otolaryngology who subspecialized in laryngology and joined us a few years ago with a great benefit to the patients in our department. Just a soft reminder before giving the mic to Dr. Tkhayil that there will be a link at the end of the lecture. All the audience should pass through it and put their information to be counted in their internal academic activity hours. So, Dr. Ahmed, sorry for letting you waiting, and the mic is yours.
Thank you so much, Dr. Awala, for introducing me. And I'd like to convey my thanks and to Continuous Education Department and to the ENT Department for giving me the opportunity to present this challenging case. We had a 25 years old lady presented from the South region with shortness of breath, change of voice, lip swelling, and difficulty in sleeping for around 6 months. All these symptoms were progressive with time. No other positive past medical or surgical history, no known allergies. And she had a course of oral steroid for around 1 month in the South region with minimal improvement. When she came to us, she couldn't sleep even lying. She was sleeping in sitting position. When we saw the patient in the clinic, she was stable, saturating 95 for room air, but having a noisy breathing. Her facial examination shows lower lip swelling mainly, and nasal examination shows turbinate hypertrophy, and her nasopharyngeal examination was clear. Her laryngeal examination shows severe supraglottic edema, and we couldn't visualize the vocal folds or even the false vocal fold. And this is her flexible scope. The first time we saw her, and shows ballooning of the epiglottis and balloonings of the arytenoids, a typical pictures of angioedema. So we admitted this patient and we started her on racemic epinephrine and steroids. On May 3rd, 2018, I did for her tracheostomy under local anesthesia, and I took multiple biopsies from the supraglottic area, and I did for her laser supraglottoplasty. And after the tracheostomy, that's what her larynx looks like under GA. And even I couldn't pass the 4 mm rigid telescope in the supraglottic region. And I couldn't visualize the subglottic region with the 4 mm telescope. And I needed to change it to pediatric telescope, the 2.7, so that I can visualize the subglottic region. And this is after changing the telescope to a small one. I could see the subglottic region, which was clear, and the glottic region was clear from the disease. So the disease mainly in the supraglottic region, affecting the epiglottis, arioepiglottic folds, and the arytenoids. So I did arioepiglottic fold lasering and incisions, and I did the paper pot technique to reduce the edema over the arytenoids by laser, and I took multiple biopsies, and that's what we did in the first operation. After that, I did ballooning to to stretch the supraglottic area and to reduce the edema. Then I consulted our allergic ENT consultant, and I consulted other colleagues from medicine, and I did most of the workup. C1 esterase was with the normal because we were thinking about angioedema. Fungal culture were negative. C2 was high, and Nielsen stain showed no acid fast bacilli. C4 was within normal. C ANCA, B ANCA were negative. Her biopsy shows acute and chronic inflammation associated with the fibrinous transudate. And we did rust test for her, which was positive for dust mite and positive with animal protein and with seafood. Angiotensin converting enzyme was within normal. Other labs all was within normal. Antinuclear antibody was negative. Rheumatoid factor was within normal. And I consulted our immunologist, Dr. Azam, and our impression that it could be a chronic non-histaminergic, could be hereditary angioedema, which may benefit from tranexamic acid. So that was our first impression. And we started, Dr. Azam started her in tranexamic acid. I believe it was 1 gram Q8 hourly. And I downsized her tracheostomy tube to size 5. I was able after the surgery to fully cap her during the day, but she cannot be fully capped at night and during sleep. 3 months after the laser, her edema came back, and this is her scope 6 months after the laser and balloon supraglottoplasty. The edema recurred, but it's much better than the first time. We could at least visualize the true vocal fold, but I couldn't decannulate the patient because the disease is still persisting. And that's here. The trachea looks clear, subglottic region were clear, and bilateral cord mobile. So I took her again. That was in August 2019. So to take more biopsies and to do more dilation and more resection of this edema. I did for her epiglottoplasty, and I took multiple biopsies from the epiglottis, which give us a clue and the histopathology specimen. Furthermore, I did partial arytenoidectomy and ballooning of the area and steroid injection. So the second histopathology specimen shows same acute and chronic inflammation, but this time it shows there is a lymphocytic infiltration with small non-necrotizing granulomas. So we kept the patient on the same regimen, the tranexamic acid. She continued in the tranexamic acid for 2 years with minimal improvement. Also, our immunologist tried danazol for her for 4 weeks. She couldn't tolerate the drug well. Plus, she didn't have any improvement with danazol. Also, he tried Toplon, which is also hormonal therapy for her for 4 weeks with no benefits. Then I discussed the case during our meetings, and that's hair scope 1 month ago. So 30th of November, it shows the effect of the arytenoidectomy. We can see the effect of arytenoidectomy in the left side. We can see the tracheostomy tube. We can see the effect of the epiglottoplasty, and you can see the epiglottis becoming like a bifid type. It's a way to open the airway in the supraglottic edema cases. And after discussion in our department, Dr. Awala, our moderator, thankfully, she sent me this article. It was very helpful, and it changes our thinking and our plan in managing this patient. In Greece, they have a similar case with chronic laryngeal edema, and they took a biopsy and shows the same biopsy result, which is acute and chronic inflammation and non-necrotizing granulomas. And their assessment and diagnosis that the patient having sarcoidosis, despite their patient was having normal angiotensin converting enzyme and doesn't have any other organ in the body showing any signs of sarcoidosis. Furthermore, the patient was not responding to steroid. And the patient in the Greece responded very well in methotrexate. So we thought it may be the same scenario with us, and could be our patient having an isolated laryngeal sarcoidosis. I share this information with our immunologist, and he started here on methotrexate. We just started here on methotrexate, and we will see the effect of methotrexate. And the lesson I learned from this patient that we need to question our diagnosis if the patient is not responding to medical or surgical treatment. We need also to repeat the biopsy from multiple sites that may help us or give us a clue to reach the diagnosis. And sarcoidosis should be suspected in every diffuse chronic edema of the larynx, despite the absence of lower respiratory symptoms and negative angiotensin converting enzyme. Thank you very much. And any questions, please? Dr. Awala.
Thank you, Dr. Ahmed, for your kind presentation. Well, I think this is one of the multiple cases that we are encountering in our tertiary hospital with the challenging diagnosis, because the medicine is not a textbook. You will not have a fixed results of laboratory and images usually with such patients. So if there's any idea, any additions by the audience will be added to the patient, it's going to be of a great help to us. And also it might open a corner for discussions for regarding the case. So any comments from the audience? I hope that one of the immunologists is joining us. But inshallah, we will follow with you soon, Dr. Tkhayil. I think Dr. Alia has a comment, but I don't know how can we allow her for participation. Okay, you can talk, Dr. Alia.
السلام عليكم، يعطيك العافية دكتور أحمد. صراحة فعلا interesting cases. بس سؤالي الآن اللي فهمته أنا it is the diagnosis was sarcoidosis, the cause of laryngeal edema is sarcoidosis. طيب. From your treatment before, did you start this case on steroids? I didn't get this part.
Yes, we started here in a steroid, good dose, around 50 milligrams, more than 1 month, and it was ineffective. So.
طيب الساركويدوسيس عادة بيستجيبوا مع الستيرويد.
بس الحالة اللي في جريس it was the same. They give her high dose of steroid for 1 month, and it didn't respond. That's why this case report in Greece, it opened our mind that it could be the biopsy shows chronic inflammation, and it shows granulomas. And they said there is some kind of sarcoidosis. They didn't respond to steroid. And they have a good result with methotrexate. That's why our immunologist just started 1 week ago the methotrexate.
How's the patient after the 1 week of methotrexate? She's improving?
Till now, we will contact her, and I will bring her to the clinic after a couple of weeks and examine her. We will see how is the result.
Any associated factors causing this edema? يعني patient هل هو smokers?
Nothing.
Nothing.
All history were negative. No allergies to certain food, medication, smoking, even bukhur, other things. It was very, very challenging case. And a couple of months ago, I make a report for her, and I recommended her to be treated in International Laryngeology Center because I was struggling with her for 1.5 years, and I couldn't reach diagnosis.
What is the opinion of the pathologists? Are they agreed with this diagnosis, or they need more biopsies or more consultation outside the hospital or outside the kingdom?
Yeah, we hold a meeting with the pathology department. The slides were reviewed by Dr. Hatton, the head and neck pathologist. And also the slides were reviewed in Mayo Clinic in the United States. Okay. All of them, they agreed about the diagnosis. It's acute and chronic inflammation with granuloma. And all of them, they didn't have a clue what is the disease causing this problem. And once I sent this article, the case report, to the pathologist, I have their contacts. They were very happy and delighted, and they said most likely it's this unique kind of sarcoidosis, which is not responding to steroid, and why not to give the same regimen and medical treatment, the methotrexate, and to try the methotrexate.
ممتاز. سؤالي بس الأخير للدكتورة ولاء. دكتورة ولاء، أنت ذكرتي إنه there is many cases in the hospital.
Yes.
All adult or mixed adult and pediatric?
No, there's mixed adult and pediatric. We struggle with diagnosis, and we find we diagnose them with a very unique diseases, and we reported some of them, but a lot of them not yet reported. But inshallah, we are working over them.
But as treatment-wise, still they are under observation.
No, I mean not per se for the laryngeal, because I'm working much more in a pediatric field. So I'm talking about the pediatric otolaryngology. We are facing unique cases, and we are reporting some of them.
Okay. يعطيك العافية. Thank you very much.
الله يعافيك. هلا الله يحييك. Any other question? I think there's no more question, and the link will appear shortly for you. I don't know if it's apparent now, and I advise all of you to fill the link to be counted for your internal academic hours. And thank you for everyone.
Thank you very much. Shukran, Dr. Wala, and thanks for the audience. Thank you.
يعطيك العافية دكتور.